When you have a fracture of the first metacarpal, you can have a fracture of the base, and it's only two pieces, the main fragment and that slight fragment on the medial side. Or you can have more than one fragment, or you can have a fracture which is just about the base but is extra-articular. And these are the three things, main things we see in a fracture of the base: intra-articular one piece, intra-articular more than one piece, and extra-articular but at the base. When there is a single piece which is intra-articular, it's called a Bennett fracture. And what is happening here, on the medial side there is a strong ligament which is preventing this fragment from getting out of alignment. On the lateral side, on the radial side, there is a strong pull of the abductor pollicis longus, which is the dynamic pull. And therefore, once the fracture occurs, there is a dynamic pull of abductor pollicis longus and static force of the ligament of the oblique ligament. And under the pull of the abductor pollicis longus, which is a dynamic very strong tendon, the whole thing subluxates. And therefore, for all practical purposes, the fracture of the base of the first metacarpal is a unstable injury. And therefore, being an unstable injury, that will worsen over a period of time, and therefore they all are candidate for surgery. So fracture of the base of the first metacarpal intra-articular Bennett fracture is a candidate for surgery. Coming to the Rolando fracture, this is a fracture of the base, but there are more than one piece at the base. Because it is fragmented into multiple things, putting K-wire is practically not possible. So if there are more than one, more than two, you can think of plating, but for such a extensively comminuted thing, you require some other method. And the method of choice for me is a K-wire. If you have a fracture of the base, which is extra-articular, what is happening, because of the pull of the adductor pollicis, the distal fragment is going medially, and therefore the span, the opening of the first web space is getting diminished, and therefore this angulation of the base, which is called as epibasal fracture, has to be reduced so that you can open up the first web space. And how do we do it? Of the choices that we have, my preference is 2 or 3 K-wires to keep it wide apart. There is angulation. You can treat it multiple ways, but what is important to know is the extent of angulation of these things. You can treat it conservatively or operatively. Fracture of the fifth, these are boxer fractures. This happens because the impact, the distal fragment of the fifth metacarpal bends forward anteriorly. It may flex by 40 to 70 degrees. This is the time when you talk to the patient. You may, if you are seeing this knuckles here, you will not see the knuckle because it is flexed. As against if you operate, you can of course have to you might have some residual stiffness. So patient has to be a part of the decision making. Fracture of the metacarpal, when do you operate them? If there is rotation, if there is shortening, there are multiple metacarpals, it's open fracture, it's a replantation. Now what happens if there is a shortening of more than 5 millimeter? If there is shortening of metacarpal, the extensor tendon will become relatively lax. If the tendon has become lax, the patient will not be able to elevate the finger. If the patient is not able to elevate the finger, because it is drooping, he is trying to grab something, the finger will flex further, and there's go, it's a handicap. So patient, instead of using this, patient start doing this way. And therefore these have to be, length has to be restored so that the extensor tone and excursion can be restored as well. There are various implants which are available: splints, K-wire, screws, plates, and external fixator. For me, the implant of choice is a K-wire. I think in 30 years I have probably not used a single plate in metacarpals, and therefore I'm comfortable with K-wires. All the patients are followed up, and important thing that gives good result is not the implant alone, but is the mobilization and the immobilization. If you don't mobilize them early, if you don't immobilize properly, you can get a very stiff hand, and therefore post-operative care is very important, whatever the choice of implant you have.